Good evening to everyone and welcome to today's session. Probably today is our day 7 in ophthalmology. We have started with glaucoma, cataract, and then we progressed through nearly around 11 topics. Today we will try to discuss about 4 main topics: CRAO, CRVO, CRAO and CRVO, and hypermetropia. Already we finished myopia. Then we will also discuss about few things on the sympathetic ophthalmitis, on which a lot of questions come. So let us make the great beginning. We welcome our online classmates Vinod, Rohit, Amrita, Parvati, Kumar, Tirupati, Vizag, etc., etc. So let's make the start. Retinal artery occlusion. What is the common etiology, doctor? If you look at elderly people who are suffering from hypertension, when they present with a sudden loss of vision, we should always think of this possibility. The occlusive disorders of the retina are more common in case of the elderly people with hypertension and other cardiovascular comorbidities. Whenever the artery occludes, the decreased blood supply will lead to ischemic injury, and you find a white retina which is ischemic. And you can also find a plaque, which is the one responsible for the occluding the retinal artery. Now, what are the common causes of the retinal artery occlusion? Is one of the important and favorite MCQ of the examiner. Atherosclerosis-related thrombosis at the level of the lamina cribrosa is the most common cause for the development of the CRAO. This is one of the favorite MCQs of the examiner. Whereas emboli, which come from the carotid artery, because carotid artery is branches of ophthalmic artery, who will be ultimately giving rise to central retinal artery. The emboli from the carotid and cardiac origin are the second common cause, and retinal arteritis with obliteration can occur in the people who are having genital arteritis. That's the reason we should aggressively treat genital arteritis. Otherwise, the involvement of the ophthalmic artery and subsequently retinal artery and an occlusion will lead to the development of blindness in case of genital arteritis. There can be retinal periarteritis which can occur in vasculitis, as in polyarteritis nodosa, SLE, vaginous and scleroderma. Then any vasospastic episode can lead to the development of amaurosis and sudden blindness, and raised intraocular tension. Few people have thrombophilic disorders like hyperhomocystinemia, protein C, protein S deficiency, factor V Leiden. They all can develop CRAO. But ultimately what you need to remember, single most important point in the tomorrow's exam, atherosclerosis-related thrombosis at the level of the lamina cribrosa is the most common underlying cause, is what I want to underscore to all of you. It's more common in the case of the men, usually unilateral. Now, there are 2 kinds of retinal artery occlusion. One is central retinal artery occlusion, other is called branch retinal artery branch occlusion. So, a sudden painless loss of vision is the typical presenting symptom in case of the central retinal artery occlusion. A lot of times MCQs are asked on one important point: is it painful or painless? You should emphatically remember CRAO, central retinal artery occlusion, is responsible for painless loss of vision, is what I want to underscore. Since retina is suffering from ischemic injury, there is a loss of the pupilary light reflex if you throw light on that damaged retina. If you do ophthalmoscopically, you can see that the retinal arteries are markedly narrowed and the retina typically become milky white because of the edema, and the central part, which is in the macular area, that will stand out in prominence with all this milky edematous retina around, and that looks like a cherry red spot. Cherry red spot occur because the vascular choroid, which is underlying the macular area, will be shining out through a thin retina. So that is responsible for that cherry red color, is the underlying choroid's color, is what we need to remember. And if you look at the retinal veins in case of the retinal artery occlusion, they will show segmentation of the blood column, which is called as cattle trucking. A cattle truck is passing, if you look at the wheel, it will be discontinuously braking, right? So that is called as the blood column and the retinal vein showing cattle truck appearance. Is a classical feature of the central retinal artery occlusion, one of the favorite MCQs in the exam. Cherry red spot and cattle truck appearance. You should remember the central retinal artery occlusion. After a few weeks, the retinal edema will subside and there will be atrophy which will be developing, and there can be a optic atrophy. Consecutive optic atrophy can occur, secondary optic atrophy, because of this retinal ischemia. Now, another very common question which is being asked is, for this kind of a cherry red appearance with a surrounding whitish edematous retina with a central pink area, so cherry red area, what are the other causes? Like a parrot you must rattle out in the tomorrow's exam: Tay-Sachs, Niemann-Pick, gangliosidosis, Berlin's edema in the case of the trauma, and Gaucher's. Any of them can be responsible for the development of a cherry red spot, is one of the favorite hot spot in the MCQs of the examiner. Now, how do you want to manage? The retinal tissue cannot survive even for little time if it doesn't get the blood supply. So that is the reason it will suffer injury. So first lower the intraocular pressure. You give intravenous mannitol, intermittently give an ocular massage, and that ocular massage will aid the arterial perfusion and try to dislodge the embolus. And sometimes even paracentesis of the anterior chamber is also done in order to relieve the ocular pressure. Then we also give vasodilators, like a mixture of 5% CO2 with 95% oxygen is also one of the practices in management of acute retinal ischemia in case of a CRAO. We give anticoagulants, can be helpful sometimes. Intravenous steroids, especially if it is genital arteritis. Without waiting, watching for a biopsy report, you need to start methylprednisolone if you are suspecting. And why genital arteritis becomes a close differential diagnosis? Because elderly people with a thrombus forming due to background atherosclerosis is also elderly. Genital arteritis is also commonly found in elderly. So if you are not very sure also, you need to start steroid, because in genital arteritis, early the steroid, lesser are the chances of any visual catastrophes. Now, what are the complications of the CRAO is a very, very important question. That's right. Nina is adding up one more point to us. Painless loss of vision, differential diagnosis. What are all the different causes leading to painless loss of vision is a favorite question. So Nina is proposing retinal detachment, retinal hemorrhage, vitreous hemorrhage, occipital infarction, anything can lead to the development of painless loss of vision. So that we need to be very sure. Now, what are the complications of the CRAO? Neovascular glaucoma can develop as a delayed complication is what we need to remember. So this is in summary, doctor. So what are the 5 buzzwords you want to remember? Cattle truck appearance, cherry red spot in the macula, and atherosclerotic thrombus being the most common underlying cause, followed by emboli, seen in elderly people. So these are the essentials. Now, if you look at retinal vein occlusion is more common than arterial occlusion. Once more in elderly people in their 6th to 7th decade of life, even central retinal vein occlusion, it is the same risk factor. Now what is the etiology? Why should a thrombus form in a central retinal vein? In an elderly person, due to the arteriosclerosis, when the retinal artery becomes sclerotic, the retinal artery and the retinal vein will be sharing a common adventitia. So that is the reason that sclerotic retinal artery will put compression on the retinal vein and lead to stagnation of the blood, which predisposes to the thrombus formation. Then hyperviscosity conditions can predispose to the central retinal vein occlusion. Polycythemia, hyperlipidemia, macroglobulinemia, any hyperviscosity state can be a risk factor. Then typically the patients will be developing similarly periphlebitis retinae is one very important entity. Just like our peripheral vessels will undergo a periphlebitis, even a similar thing can happen in CR vivo, and that can predispose. Then any raised intraocular pressure. If you take the patients who are having primary open angle glaucoma, those guys are at a higher risk of developing. CR vivo is more common in them. So that is the reason they said any raised IOT, intraocular tension, can become a risk factor for the development of the central retinal vein occlusion. Any orbital cellulitis, facial erysipelas, or if there is any cavernous sinus thrombosis, yesterday we have seen, no, retinal vein will be draining ultimately into cavernous sinus, right? So that's the reason any cavernous sinus thrombosis, anything can predispose to the development of a retinal vein occlusion. Now, if you look at the CR vivo, there are 2 types of subclasses, doctor. 2 types of subclasses. I think Akhil is having some problem with the transmission. Just ask support to help him. You can use some third-party tool like NetSpeed to check first of all what is the upload-download speed of your internet connection. So if it is 1 Mbps, you are like on a jet fighter plane on internet or a bullet train. So if the internet is good, you will enjoy the live broadcast. Minimum requirement. Nowadays 1 Mbps has become the rule of the life. So that's the thing. So hope Akhil will get some help from that. That's good. Now, non-ischemic CR vivo, ischemic CR vivo is the broad classification of the CR vivo. Non-ischemic is also called venous stasis retinopathy, and hemorrhagic retinopathy is the name given for the ischemic CR vivo. Then we can also have branch retinal vein occlusion. These are the broad divisions. Now let us see 2-3 salient features which are frequently asked about each of these subtypes of CR vivo. Non-ischemic CR vivo. It is much more common than the ischemic type of a CR vivo. 3/4 of CR vivo are non-ischemic in nature. In this there is mild to moderate visual loss in these people. If you look at fundus, in the early cases there is a lot of venous congestion, tortuosity, flame-shaped hemorrhages in the periphery, and there can be mild papilledema, mostly without any macular edema. But in the late stages means after 6 to 9 months of having a non-ischemic type of a CR vivo, there will be sheathing which will be developing around the veins, and the macula will show cystoid macular edema. So doctor, do you want to treat this condition? Treatment usually is not required for non-ischemic type of a CRVO. It will resolve in 50% of cases. But in the remaining people, if there is a cystoid macular edema, if it develops in the macular part of the retina, if edema develops, then the visual loss will develop. And if cystoid macular edema is developed, there is no effective treatment to resolve that. So few people get benefited by taking steroids for about 8 to 12 weeks. Then what we have is called ischemic CRVO, is the second type of variety. It is also called hemorrhagic retinopathy. It is less common than that of the non-ischemic type of CRVO. There is an acute sudden occlusion of the central retinal vein with a marked sudden visual loss, just like in CRVO, in case of ischemic type of CRVO. But if you look at the fundus, what is the classical feature? Splashed tomato appearance. Once more, a hungry ophthalmologist working in the kitchen preparing a wedding day dinner for the wife has discovered splashed tomato appearance. Why splashed tomato? Because in ischemic CRVO, there will be lot of hemorrhages spread across the entire retina, hence called splashed tomato appearance. They will also develop soft exudates, papilledema, etc., etc. Now let us look at it. This is a typical case of CRVO. There is one more name which is being given for this splashed appearance, splashed tomato appearance ko, aur ek naam hai. What is that name? Blood and thunder appearance of the central retinal vein occlusion is what you classically come across. Blood and thunder appearance is what you need to remember. Now in the late stages, there is a lot of sheathing which will be developing around the veins, and now comes a very, very important question. At the optic disc, there is a lot of neovascularization which will be developing, even in the periphery. And maculum will show pigmentary changes in cystoid edema in case of this. So if you do a fluorescent angiography, you can be able to appreciate the presence of highly proliferative neovascularization and cystoid edema. What is the main cause of the blindness in case of an ischemic type of CRVO, doctor? It is the development of this macular edema. It is the underlying cause for the severe loss of vision in these people. Now, doctor, are there any differentiating features whether the CRVO is a ischemic type or a non-ischemic type? Is one of the favorite MCQs of the examiner. Very simple. Presence of visual field defects, relative afferent pupillary defect, and a reduced amplitude of the B wave in the electroretinogram. These are the differentiating features between which are seen in ischemic CRVO but not in non-ischemic CRVO. But which is more common? Non-ischemic CRVO is more common than ischemic CRVO. There can be, this is an example of our earlier topic, central retinal artery occlusion. So there is a vascular filling defect if you happen to do an angiography, vascular filling defect in case of central retinal artery occlusion. Now what are the complications which can develop in CRVO? As I told you, there is a neovascularization. Where will that vascularization will be growing into? Into the iris. Rubeosus iridis and iris ciliary body, angle of antechamber, they are all closely related, no? So rubeosus iridis and neovascular glaucoma will develop in about 50% of people within about 3 months of time in the case of ischemic type of CRVO. So this is also called as 90 days glaucoma. This was asked umpteen number of times in entrance. What is the underlying cause for the 90 days glaucoma? What is your confident answer? Ischemic type of CRVO. Because of the neovascularization and rubiosis iridis, glaucoma developing within 90 days in about half of them. Hence called as 90 days glaucoma. There can be a vitreous hemorrhage which can develop as a complication. Then proliferative retinopathy can develop. This is another classical example of that abundant neovascularization of the iris which is being developing in a patient of the CRVO. So how do you treat, doctor? We know only one technique very confidently to treat whenever there is any ischemic area leading to development of neovascularization. What is that technique? Burn the retina. So pan-retinal photocoagulation, it will be preventing the neovascular glaucoma in all the patients of ischemic type of a CRVO who have developed a lot of capillary occlusions. But when CRVO, ischemic CRVO is acutely presenting, we should not try out PRP. 3 to 4 months time ke baad, when most of the intraretinal blood got absorbed, then we should do the photocoagulation. And we can also use cryo-application if the media is very hazy for you to do photocoagulation, pan-retinal photocoagulation. Now let us pick up a couple of comments on BRVO, which is the branch retinal vein occlusion, as what you can see here. The branch retinal vein occlusion. Compared to CRVO, BRVO is much more common. Within CRVO, non-ischemic type is more common than ischemic type. So these are few things which we should not forget. Now, with BRVO, which branch of the retinal vein can be involved? It can be the main branch at the margins, disc margin. It can be the major branch vein away from the disc, or it can be at the AV crossing. Arteriovenous crossing may one of the branches can develop occlusion, or most worrisome is the macular branch of the central retinal vein is there. No, if it is occluded, it is more blinding in nature because it leads to cystoid macular edema, which is very, very catastrophic complication. So this is an example of a macular edema which is developing in case of macular branch retinal vein occlusion. So how do you treat this, doctor? We can use a grid photocoagulation instead of pan. If there is any chronic macular edema, grid photocoagulation, and if there is neovascularization, we do a scatter photocoagulation. So that is considered to be the management of choice. So this is all about CRAO, CRVO, BRVO, ischemic, non-ischemic, cattle truck appearance, and macular edema, central and branch retinal vein occlusions.